So let's start with our this episode of the Meet the Masters class. And today our theme is high definition IVUS in complex PCI.
Get me
And this, of course, our expert panelists with Arun Chopra, Gajendra, Ravi Kumar Alluri, and Kala Chivalavan. But there are few others which will be presenting, and Subhash is the moderating, sponsored by Boston Scientific India, ESCC, and Mount Sinai Fuster Heart Hospital. Myself and my associate, Dr. Keeney, will be performing the case. This is our episode number 24. So this is the fourth year now. We do 6 per year and 4-year end, 24 this month. It's a 55-year-old patient, end-stage renal dialysis patient. Did not have any much coronary history before. Until recently started having some chest pain and high calcium score, which we expect in the renal failure patient, and even with the high calcium they were able to do CT-FFR, which was very positive in LAD and RCA. Patient has other things are controlled, as you can see there. Although patient is we can call it diabetic actually, A1C is 6.5, but he denies it, so pre-diabetic or so. CRP is high. We have seen it in many patients with the renal failure. High CRP does not really indicate that it's the CAD. High CRP is an indication of CAD also. Good EF, patient was on good medical therapy. Was started on Imdur a few weeks ago in a preparation for the angiogram, and angiogram actually showed calcific two-vessel disease with a normal LV function, and we'll show you that. Intervention was done into the LAD, and now today is the right coronary artery, multiple lesions, and plan will be rotational atherectomy. By definition of the OC criteria which we show, this patient will have a two-vessel disease because diagonal is still treated about 60% ostial, but complex lesion of the RCA. With that note, Anu, can you show what we have so far?
That was LAD, and then...
No, but do a better picture of the LAD, or that's it? We had a complex symposium, our structural symposium yesterday. I think fellows are a little tired, didn't have a full breakfast.
No, these are not... yeah.
Look at this. You need a better picture. But anyway, it looks all right. There is a diagonal disease left, circumflex is good. Let's go where the money is. Money is on the right side. We have the right picture.
The guide does not sit well because, we don't have the mark guide anymore. So it's mostly in the conus. So we're going to wire it and then take a better picture.
I see. Okay. So we are ready for the right coronary, which we announced on the our e-blast, and here this is we go with the Lima guide. I know very rarely in India they use the Lima. We use the Lima guide very freely for the right coronary, and of course with the tough cases we go with the AR or AL. Yeah, let's advance a little bit more,
no, it's going
and then we'll see. Yeah. Go a little more. Good. Yeah, good. Hold it there now. So now your question was that how you
go to the no-talk guide also.
Yeah.
No, it will going into conus. It's going
to still conus is still. Okay.
Open.
Yeah.
Hold on. What is that? 3DRC, right?
Yes. Yeah, that's the only one left. So key is that this case,
dark blue.
This case we need to have a different catheter. Our usual Lima catheter didn't work. Could have used the FR or JR, but we are going with the no torque or 3DRC. Throw it. One second. I know that you guys just completed a CSI meeting and I could not come to CSI just because always overlap with my valve symposium. How was overall CSI?
Yeah, it was a busy show, sir.
Yeah, very busy, yeah.
There was some problem due to the airlines glitch.
Indigo big time. Airlines, yeah, Indigo.
Yes,
big trouble.
Not to function for 2 days, and that screwed up the program for some people.
Yeah.
I myself had my flight cancelled. Rescheduled. Came in later.
But is the Indigo back in business yet or no?
Uh, Yes, it is, but there is some inquiry going on.
Ah,
People are trying to file a case against them. They are asking for damages because they knew 2 years in advance that they have to do this and they failed to do anything.
yeah.
So, not
That's
fulfilled
called
up
the
to
greed,
guidelines.
Okay, quick, take a
greediness.
picture.
Okay. You ready? Nitro, a little bit.
No need.
Okay. Okay, now we got, this is a no torque guide.
3D RC.
3D RC, yeah.
Oh, yeah,
It's
yeah.
still the
Even
same.
that.
Oh, come
Go
on.
down.
Chorus.
No, no, no. That's not
Yeah.
the thing.
Because anytime you do a conus
Okay.
injection, could go into V fib.
Okay, there.
Yeah, let's
Okay.
keep it there. Let's
Other
put a
thing
wire.
is, get us FR also.
No, 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 this will be okay. This will do, yeah.
We
That's good.
tried the same earlier.
No, no, what is this? No, don't give me this. This is the IVUS. Yeah. Let's go with this.
Hmm.
Yeah. Once you go, we can move it now. Or otherwise, AR will work here. AR2 will be a little down pointing. I think AL will be too big, but
No, no,
AR.
no. I think just regular FR may be okay.
Okay.
Let me see if this also
Okay.
does not go, then
Yeah.
we change to. Yeah.
Okay, good. Now hold it here.
Mhm.
And you come here. You'll show it, Sabina. One not yet. I'll tell you when. Good. Yeah. Yeah. Oh, sorry. Anyway, bring your catheter because we are in the RV branch now. Yeah, good. We are good. Okay.
No, no, no. Hold on. Yeah. Guide can't keep coming
Yeah.
out.
I know, but put this one now. Go forward. Now, do you want to go to extra support, rota extra support wire? Now, is the extra support wire available in India, rota, or no?
Yeah, yes, it's available.
Okay.
We also have their new glide wire.
Your rotor
You
drive,
can
your rotor drive now. Yeah.
rotor
Rotor
drive.
drive, floppy or extra support are the one better wires. But in this kind of case, you will not go directly because you saw it. Required a lot of manipulation. And now with this, we should take a rota and then we take a picture.
Okay, you can take a picture.
No, take
now.
this one out. You don't want this one. This will be occluding. Oh, sorry.
I don't
No.
think so.
Let's
Leave
change
it
to
there.
rota. Let's change to rota and then, yeah. Want to go with rota extra support?
Okay.
Okay, extra support wire. Rota extra support.
You have to. You can't just talk like that.
So, Dr. Sharma,
Yeah.
which are the cases where you would prefer a rota extra support
Yeah, I
over
would
the
say that
usual floppy?
ISR cases or distal where you need osteal lesion, you need little support. So that we extra support we use in 10% of cases. 9 are floppy, and good indication is the osteal lesion where you have to disengage the guide. That's one. Secondly, is in the ISR because what happens extra support keep you in the lumen because otherwise it's a little floppy. So those are the two major indications. Sometimes very rarely the distal vessel when you cannot get in. So in that particular case also we'll use the rota extra support. So about 10-15% use extra support, and but by and large is the rota floppy because it's the tip is the shorter for the rota extra floppy, or I mean now we call it a drive, and so that it's better torqueable 1-to-1, and then of course the transition is shorter. So that's why the floppy is the rotor drive floppy is the first one of the choice. Now they have not done much changes, you know. Still, this is one of the best, I mean ancient, but the best technology. I know the particularly the orbital, but orbital has this one negative trial. Actually, we saw now there has been a big significant drop in orbital use in the United States after the Eclipse trial. And of course, there is a decline in both rota and orbital use since because of the increasing IVL. So IVL is used now in almost 8%, 8 to 9% of cases, rota about 2.5, and orbital about 1%, little under 1%.
So these are American figures.
American figures, yeah. So total about calcific lesions, they are the latest from ACC and CDR. Remember in America, every PCI you do, it goes to the National Registry, American College of Cardiology. And we get every quarter updated one. And just to give example, Now we from the 28% IVUS PCI done in America, 28%. Of the 28%, 90% is IVUS and 10% is OCT. I think in India much more OCT is done, but here is a 90 and 10. All right,
Yes.
Kiski, what was the
Yeah,
latest figure?
yeah. But growing, it's definitely
But
growing.
OCT is growing. OCT used to be 5% about 2 years ago. Now so many OCT trials have really made it positive, going up. Now with the new design, particularly with the saline features, and hopefully this number will go up. Okay, Anu, tell us what your plan is, what you have. Now we can show.
You have this RCA,
Hmm.
proximal
There is no stent,
segments.
all calcium, severe calcium.
Yeah. And then you actually have a distal lesion also.
Yes.
Question is, what's the burst size you want without imaging?
Yeah. So I think to me it's a long lesion of the mid RCA, and then there is a distal. I think we should first burst should be 1.5, unless our friends want to have a different opinion. 1.5. Yeah.
No. I think 175 is okay.
Huh? You want 175?
Yeah,
Okay,
yeah,
175. All right. Under deciding 175, I would have gone with the 1.5, but that's okay. The key is nowadays one bar. Second bar is your IVL. Very simple. And knowing that by year end, next year there will be many other IVL companies will come. I know India, Merrill already came with a new IVL. Hopefully it will be a little cheaper, because the current one is 3 lakh rupees, which is again very high. And I'm so happy that Merrill has come with a new impeller device. And I'll be using the first case on 27th December in Jaipur, because all the 5 other impeller catheters we have used. And we will be again, the very promising is the Magenta Elevate trial ongoing, and it's a 9 French. Very good results against impeller, and this is fantastic device, 9 French. And same thing, the tower has gone down to 8 French. There is a stent called Miras Seagull, which is 8 French tower. Early feasibility study has been done with the 8 French tower, using with about 15 patients. Now they are starting the randomized trial. 8 French. I mean, can you imagine? You go to 7 French, we'll be doing a tower by the radial in next 1 or 2 years.
That's a good one.
Yeah.
Yeah.
3 or 20, yeah. Okay, so we
3 or?
decided 1.75, yeah.
Distally, I don't think you need 20. Why don't
No,
you take a
doesn't-
15? So you put a 16 stent distally, and proximal you put a long stent. I mean the
That's
mid.
okay, yeah, that's
Huh?
20 is good.
No, no.
You opened that already, yeah.
Oh.
So, Dr. Sharma, I presume there was no plan to birth the distal lesion, and that is why Dr. Anu chose 1.75.
No, I think
because
still should go to
basically
distal, no?
required is actually proximal lesion.
Let's see.
No, we are going, yeah,
no,
we'll see.
I would say,
We
you know
could-
what? The dry cine will tell us here.
Okay.
Yeah, I mean, there is distal also very calcified. I mean, I would call it a severe. Look at that big chunk.
Good.
But
Could
in
be
this
even
case,
nodule.
1.75 is bigger.
Yeah, I would say, but anyway, let's try. I mean, as I said, my was the 1.5, but this is 1.75, which is okay. Check the speed first. No, before
No,
we go.
Why? We never check.
No, we always do. Okay. Yeah. You know, actually, Anu said that don't need to check because it comes
Never
set.
check, yeah.
Yeah, no. 150. We have made it by the company. Keep going now.
No, wait. Now check again because it's 146.
It comes with a 150. Yeah, see, 150. Always come 150.
Yeah, we never check.
Set by the company. As said that there is no need to check nowadays. The tachometer is not required because we have set it now. You can go to 180 if you want. That's a different story, but that's what comes by the factory. Push and pull, and our fellows are very, we have 8 international fellows. Sabina Kumar is our regular international fellow, and then we have Prithvi, who is the hybrid fellow, research and intervention, and then become the international fellow next year. Okay, so we have push and pull, come up to the ostium.
It's not going. So you know what? Let's do Dyna. Hold the
Yeah.
wire. Press brake release.
Yeah,
Okay.
good. That's it. Yes, see what we showed, that anytime you have difficulty, just advance the device on the Dynaglide. cause less trauma than push and pull, and then you cause the dissection of the osteal RCA. Okay, and we start.
140, 145, 150, 45, 5 seconds, 35, 40, 15 seconds, 40, 25, 20 seconds, 40,
Pull back and wait.
21, 40, 22.
Yeah. So you saw that if there is a more than 5,000 drop, empty triangle comes out with a brown, and if it's more than 10,000 drop, becomes a complete triangle. And of course, more than that, it will become red. So I think we are trying to put that kind into the system. So look at the pacemaker need. That this patient needed a pacemaker because of so much calcium. Usually we try to avoid pacemaker nowadays.
130,
Nice.
130, 10 seconds, 130, 30, 15 seconds.
Yeah. I think you can go to the distal also, the way it's happening.
No, we will go to
Give the
distal. Let's,
atropine here.
A little bit atropine.
Yeah, because
it's off
this is the
pacer.
case, I'll need to give atropine because that's the atrial kick.
Lot
You get
of
a blood
fluids,
pressure.
right?
With a pacemaker, blood pressure always will go down 20 points with the atrial kick. And I think things went very smoothly. There's no ST elevation in the native leads, non-pacemaker leads.
130,
Yeah.
30, 5 seconds, 25, 30, 10 seconds, 30.
No, you did not cross the distal lesion yet. Yeah, we have to just do 1, 2. Yeah, now you have to advance on the Dynaglide. You go. Good.
Okay, stop.
Yeah. So you see the birth to advancement on the Dynaglide with a brake release. Yeah.
30, 30, 5 seconds, 30, 30, 10 seconds, 130,
Same tacking motion, touch and come back, touch and come back. Yeah. Now once you are there, you can do a good polishing.
40, 40, 20 seconds,
Okay, start coming out.
Yeah.
Get the run through wire. And then we'll IVUS, right?
Yeah. Now we are going to the IVUS after that. Here, come here. Pay attention. Free it up, please. Good. No. Keep that attached. Remain. Till we come out, then you take it out. Good. Now we can take out. Okay, let's take a picture, put a run through wire, and then we understand what it is. It is a calcium nodule, calcium plate, what it is, and so. There's a new classification is coming with the nodular calcium. Okay, let's take a picture now. There's some ST elevation. So far, so good. Little verapamil.
No. Patient already is bradycardic.
Okay.
No need.
Good. Okay. Yeah, so if you want to avoid putting a pacemaker, you give aminoflin and atropine before your rotor run. 300 milligram aminoflin, particularly radial, we would not have put a pacemaker. There because it makes extra effort. Groin, we always very low threshold for putting a pacemaker in these cases. There's still some ST elevation you can see. Guys, continue to show the hemodynamics on one side. There's a little bit of ST which is expected with such a calcific lesion. And now we are ready to do the IVUS.
Yeah, good.
Yeah. Remove the rotor.
Is key on distal lesion also?
Yeah.
Yeah, we
Remove
can,
the
if
rotor, you don't need
if it closed.
No, it's okay. We need it. Things will not go easy.
Oh, it will go. Now it will go. With the bar of 1.75, 100% will go.
Guide is not
Yeah.
the best guide.
Trust on 1.75 bar. It will fly.
So we do first pivot, 4 millimeter per second.
Okay, we'll go to the distal.
Yeah. Yep.
No, it's in the
I'll
mid.
take the rotor. So
Yeah,
this
it went.
becomes-
No.
Why you want to leave rotor wire?
It's okay. You can do it.
Okay, still it's on the plug. Do we go a little more distal? It's in the lesion.
Okay.
Good.
Yeah, now it's good. Okay, start
Okay.
pullback. It's distal RCA.
You can put a IVUS on the main screen.
It's coming. Like 360 calcium, but I see some like shaved surface of the calcium. Now this is a gap. Mid RCA, but here's also some plaque. Yeah, a lot of calcium. Yeah,
Wow.
360.
Lot of 360
Yeah,
degree
very
calcium.
diffuse. Wow. Wow.
Wow.
Yeah. Wow.
The typical of the renal disease patient.
Yeah.
The whole artery is calcified. Some
Yes.
places plaque and no plaque.
Yes. And the start of the pullback is kind of like 2.8 vessel. And the distal lesion, this is after the rotor. I see some like a crack even just by the rotor, but still a lot of calcium. And I see reverbulation. It means the surface of the calcium is shaved.
Okay.
So yeah, multiple reflection. So but here still distal RC
This is
has
circular calcium.
yes 360 calcium. We might need additional something.
Huh?
I mean we might need more.
No, we are just going with the balloon.
Yeah.
Go
So
back.
then we can check. So this
Go
is
to the mid, that mid lesion, not the distal. Go to
okay.
the
Sure. So this is the gap.
Mid. Okay.
Then come to the mid
This
lesion,
one.
diffuse calcified lesion.
But at the mid, did it make some cuts?
Yeah, I see some reverbulation. It means the surface is shaved, but still like 360,
Yeah, see.
very tight stenosis. Of course, yeah, we can try the balloon and see the expansion. Mostly calcium sheet, but some part might be like nodule, not like dramatic. Mostly like here, 360 calcium sheet.
All right.
So, Dr. Sharma, what do you plan now?
No, we are trying to
Yeah.
decide, do we just do balloon or do we need IVL?
Yeah.
Okay.
Because of still circular calcium, but I think there are some sick cut in the calcium. I think a high pressure will be okay. And if need to be, maybe just use a cutting balloon.
Yep.
3O,
Sure,
vessel
I
is
was
3O,
thinking
right?
about-
This all the way distal is 2.8, but it's a huge like a
Yeah,
tapering.
Arun, your plan, you any recommendation from your side?
So, I was also thinking of cutting balloon.
Yeah, okay. Will be 3O once we use it. 3O cutting balloon, yeah. But let's see. We're going with high pressure again first, and we have one wire cutting balloon anyway, because the rotor wire is still there. So modified cutting balloon, poor man's cutting balloon.
Dr. Sharma,
Yeah.
would you use low speed burring
Yeah.
in such a
Yeah, I know.
situation
So
before
I know.
taking out?
Yeah, I know. I think that a lot of people are talking about that. The low speed at 100,000, 120,000, and that is that it works as an orbital atherectomy. I had not bought that concept. But I think we just go with the low speed in the sense not of the 110 or 120, but 150.
Yeah.
But so that to me, I think that's reasonable. And so key is let's keep the device for the purpose it is made for, and that is the rotational atherectomy. Unless somebody can show that by that an IVUS low speed versus high, you get a better gain. We still continue to do the same, our 150,000 RPM. And if after 4 try, the lesion did not cross, then we go to 180. And so that has been our practice so far. So we have not gone to the making a low speed of 120 and working that as a orbital atherectomy, because to me it cannot be orbital because point is it will deflect back. The orbital works because it's an eccentric crown, and that's the key. So here, if you make a low speed, to me, it will just deflect back from the calcific lesion. That is my hypothesis. I reviewed the paper before it was published, and that was my comment, but I think it was still published. We know that. So I think to me, see that perfect result. Balloon expanded. I know what you want to do now. I think your balloon expanded. Mid area, you can go a little high pressure.
No, that's not the question. See
Cutting
that?
balloon. Yeah.
Because of the circular calcium, Kiski, come look at the angio.
You want a
Yeah.
3.5 cutting balloon? Or the mid? Distal is very good.
I still think you need IVL.
No, why not 3.5 cutting balloon? Let's try 3.5 cutting balloon. Wolverine.
Yeah,
Right?
mid,
It's a-
mid part is at least 3.5 vessel.
3.5
but-
vessel, okay.
Yeah, but diffuse plaque, there is no good landing zone.
No, but look at that amount of calcium.
Mhm.
We need a IVL to really make a difference. Okay, now distally we will put what? 3O I think was too big.
No, 30 will be okay.
I would put a 20 stent.
Yeah, 3020, and this there 3.5 32. But you gave it? Huh? Yeah. Yeah, that question always comes that once you're done the rotation atherectomy, then do you do IVL or you do a cutting balloon? Now, we saw that latest trial did show that using both is equal outcome. And that was the after the rotation atherectomy. So there was no additional advantage of the IVL after rota. Now, if you did not do rotation atherectomy, then IVL gave you a better lumen, more cuts and better MSA. But if you have done rotation atherectomy, in the randomized trial of the shortcut, both IVL and cutting balloon gave the similar lumen, similar fractures and so. Your rota wire is still there? Oh, you take it out now. Now you'll be 5 blades otherwise.
Excellent.
No, can cause perforation. Remember, 5 blades are not good because 4 of the 3.5, and you put a rota, this will be the 5th blade. And I have one case.
I think we should have then stented the distal. Okay, go up.
Yeah,
I'm
that's
worried
okay.
about this.
Dr. Sharma, you have
Yeah.
any particular preference about the type of cutting balloon?
No, I think the more data are for our the cutting balloon itself. And second one will go a little slow. The otherwise, I think the scoring balloon probably have the same mechanism, but second slow.
Yeah,
The
we are
technique
slow.
basically was that you do at least 3 inflation. Yeah, for the cutting balloon, you bring it back and go. Few of the trials have shown that you do at least 3 times, and you can go easily 16 to 18 atmosphere.
Keep up. Slow.
3 inflation or second and third inflation slower, because sometimes just inflation can cause perforation of the balloon rupture. And 16 atmosphere is okay. Now, I do not go 2022 because COPS trial, COPS trial actually had a 4% perforation in the cutting balloon group. Why? Because their average pressure was 22. So I know we talked to Colombo, but Colombo still wants to go 22 atmosphere. To me, no, give some vasodilator before you take a picture. Look at the ST elevation.
Go. That's because, okay, go. RV branch.
Looks good. You want to see big? I was. The only question is, what we need at this time, the AI incorporated in the imaging. That you have done this, you want to do the IVUS or OCT and tell us, you are done with the plaque modification, put a stent. And we don't have that AI technology yet. We are even the number of fractures and this and that, it's all hypothetical. Here looks okay, but
I'll just do the mid. Okay, IVUS Kiski.
Yeah, sounds good. So
and this patient has a very high pro BNP, 40 plus thousand, although not in a clear heart failure. Elective case, but still 40,000 RPM with the renal patients are very common. High CRP, high renal failure, 3020 for the distal, yeah.
Okay.
Okay.
Yeah, check the image. Still on the plug, but I can start from here. Yeah, coming pullback. Sorry,
what happened?
Yeah, it's coming. Yeah, lumen is definitely bigger. Yeah, I see some big fractures. Calcium fracture there. Diffuse plaque.
The 3020 stent. Okay, tell us interpretation of this, AK.
No, I'm going to the mid. Go to the mid exactly where that.
Yep.
Pull back flush and get ready for the next one, Sabina.
Yeah, this got like 9 o'clock. There is a calcium fracture. It was not before. So
I think it's good. We can stent it now.
yeah.
Yeah.
But the point is like diffuse plaque where we should land it on. So
we'll put a 38.
yeah.
Okay?
Yeah.
But anyway, it's on the plaque.
3538.
Yeah.
And
Gentle
we got
pressure is better.
3020. Yeah. Give us.
Both edges on the calcium.
And as you know that many companies are combining these techniques. One of them is coming with the OCT, has the FFR in it by the Abbott. Second is the Terumo, which has both OCT and IVUS. And Kiski went there. They presented to Anu that what is that catheter? Tell us what will be that combine both OCT and IVUS, and why would you want to do both of them in one catheter?
Yeah, because there's a limitation of the IVUS and the OCT. If we have one catheter, both imaging, like it's complement image. So like a calcium thickness OCT can tell, but deep like penetration IVUS can tell like a sizing. So
Some die.
The one catheter will do both.
yes, that's the Terumo OCT IVUS.
And when can we use that catheter now? Because I got approval by the hospital.
I
Spring.
think next spring.
26
Yeah.
spring.
Oh, still far away.
Yeah.
I see. Okay.
But we will be the first one. First in human will be in Mount
Okay.
Sinai.
Yeah,
Beautiful.
in the world. Even
Go.
Japan not yet.
First in the world. Okay, go. Some die. Even from Japan we are coming to here. Okay, good. Go up.
Good.
Okay, the question is 38 or 48. Keep going.
To me, I think use 48 because there's
Yeah.
no
No, but
disadvantage.
we did not treat 48 length.
No, 48 will be okay. We'll
We
cover
did
everything.
not
Huh?
treat. We did not treat the length 48.
No, 48 will cover your mid and borderline lesion. Yeah.
What I meant, we don't stent without, since it's calcified. Yeah, good. Okay, down. 1 second, let me take another. Once we do this, we'll decide.
Pull back here. Just go high pressure. Go.
This is, why?
This is 20, 20, 40. 48 will be very good.
Go up. Oh, this, okay, down.
Those who are interested in structural, we did 9 live cases yesterday from 8 a.m. to 5, all types with a shortcut,
Ready?
valve in valve, BMV, and of course, and will be available in the on our CCC website by Monday. Yeah, I think 40 is okay. What can you do? Yeah,
3-5.
yeah, 3-5.
Okay, final IVUS after the stents.
Yeah.
Yep.
So, Dr.
Yeah.
Sharma, where do you plan to put the proximal stent? You want to leave that gap between the two stents, maybe 10-15
Yeah,
millimeters?
I think we can leave it, right?
Yeah, we are going to leave the gap.
Yeah.
There's an RV branch. We are going to go above that RV branch or slash acute marginal. You see that?
Right, right.
Yeah. So above that. Quote unquote. Let's go. Ay, ay, ay. It's too long, remember? I
Go
told you.
further. Then go to the other stand.
No, no,
That's
no,
okay.
no.
Yeah, yeah.
We may lose. We already lost one RV branch.
No, but you need
We'll
to.
be losing too many branches.
Okay, let's see scene minus that whether the area disease or not.
It's not.
No, your angiogram.
It's not.
Yeah, here. See, there is a disease there. If need to, you do one more proximal if required. But I'm saying this is good. Go touch the second lesion. I mean, why would you not touch the second lesion?
We should not do a full metal jacket.
That's okay. That area is okay. There's no other branch. Yeah. Yeah. See, you want to go otherwise that will look up 50%. If need to be proximal, you do one more. I don't think you need it, but I
Show
know a
me
lot of
in
people.
between area.
Yeah, so this is the initial pullback.
We okay?
Like area, this is a gap. Actually, the area is like a 2 to 3. Actually, all diffuse plaque, even in the gap.
In the gap,
Yes.
what is the area you're getting? 3.2?
Yeah.
3.3? So proximally, proximal edge, come back all the way to the proximal.
Oh, sure.
Where did we stop?
Yeah.
So
Even
right there, yeah. So
Yeah.
that's about 5.8.
Yeah.
Right?
Yeah.
360 calcium
then
in the
we will do
proximal
like this.
RCS.
Exactly.
No, but this is a 3.0. The distal is not
No,
3.0.
believe me, 3.5 moderate pressure and then proximal little higher pressure will be okay.
I see it's not going.
1 second. Now you have to come back with the speed.
No, that's not speed. It's not
you
going
can-
to make that angle.
No, it
48.
will go. Okay.
So
You want
we
to
did
put a
not
filter wire
dilate
with the
that.
side? Yeah. Okay. Come
I
back in
don't
the
know,
guide
unless
again.
with
Come back in the guide. 1 second. Now go again. Get
it's
a
not
filter
going to.
wire. Go.
Number one. Number two, we did not dilate that area. You have to
Mhm.
remember that. See, that's that.
Okay. You leave it there. Let's put a filter wire. Yeah. I mean, the other thing is that do you need a guide liner? No, I think the filter wire will take it.
Why don't we just put a stent? That's it.
No, no,
Leave a
just
little gap.
connect. No gap. Yeah. Okay, he's saying that there is a disease, very small area even.
You have to go on the fielder wire, not on the run
No,
through.
no, let's put this. You saw that, and even proximally there is no plaque, but the circular calcium.
Yes.
Whole vessel is calcified.
Yes.
And to bring back the stent in the guide.
Not go. I'm just telling you.
Good. So this is one way. That otherwise you have to take everything out, put a guide liner, put a side wire. It will take you back in.
Normally, otherwise, you can go on the fielder wire.
Yeah, no, that's true. Let's
Okay,
take
now
the filter wire out.
show me the die. So proximally, we are okay. If you're good, then yeah. Okay.
Good.
Okay, good. Okay, come out.
Yeah.
Okay, go up.
Touch it. Okay.
I was ready.
Yeah.
Yes. Down. Go up again. Get us a 3520 high pressure balloon, or maybe it'll be okay. Looks fine. We'll do the IVAS. Ready? Yeah. I didn't do it. IVAS. Let's do the IVAS. If everything okay, we are doing it.
We'll show the angiogram after the IVUS. Let's see what IVUS says looks good. Then we show the angiogram.
But Dr. Sharma, always angio helps the IVAS interpretation. So
Huh?
angio helps the IVAS interpretation.
Yeah.
I can focus on the where is the
Yeah,
like.
okay, let's take the picture then. He said, do the angiogram first. Okay. All right. Kiski says, angio first.
It's great.
Might need a little bit proximally, we'll see.
Need what?
Another stent.
No.
Okay, go.
doing good.
Let's see the lumen. And I
It's
know a lot
already
of people.
said 5.5.
Yeah. So question is, now what you do? And that's basically the issue in terms of optimization. And like this particular case, that how can you optimize your lesion further? A lot of studies have shown, besides just doing your imaging, that FFR, IFR, but even if you have a low value of those, modifying has not shown to be positive in any of the trials so far. So that is still not a class 1 indication. The physiology post stenting. Okay.
Okay.
Yeah, I check the image. Okay,
Yeah.
it's a native vessel. Okay, start pullback.
Main screen.
Coming. So this all RSA. Yeah, on the plug, but no major dissection. Stent looks expanded. I see small gap. The stent looks expanded. Nice, long stent.
Wow.
Now come to native.
Looks very good. Proximity.
Yeah, looks open.
And this is without the vasodilator yet.
Artery knows who's doing the PCI.
So this is at distal edge. The area is like
No, you need
5.8.
this
All
one.
right, so I think it looks very good on angiogram as well as so. Take the wire out, maybe just the last picture with the vasodilator and pacemaker
And
out.
the stent
No,
well
no, no, no,
expanded,
no.
like
Look at
area
it.
is
Still
7,
pacing. You have
8,
to wait a little
well
bit.
expanded.
Let me just give some nitro. Okay?
Nitro.
Will, only nitro. Some nitride, okay?
I don't think major dissection. No major dissection.
There is no major dissection. Okay.
Yeah, proximal area is like more than 5.
Yeah.
Yeah, stent is well expanded.
Beautiful.
Whiskey, are you super happy?
Yeah, because of this complex lesion,
Ah.
it's like a best result, I think.
Yes. No, proximal, remember 3.5 looks okay. What did you get at that area? 8.1.
Yeah, proximal. Yeah, stent
Yeah,
is
yeah,
expanded
7
like
point.
7, 8. This is the proximal part of the stent.
Yep.
So rotor and the
Can't
cutting
take
ball
it
work.
Yeah.
Different view.
No, no, once.
Little different. Yeah. Go. So you take a picture
Go.
of the ostial. Yeah. You can give some more atropine. If need to be. Wow. Wow. Beautiful. All the branches is still there.
It's a what? Tiny branch at the level of the lesion. Look at that. It's gone.
No, it's still there. No, right there.
It's coming back.
Coming back. Coming back. So everything looks very good. Tell us
Can
our.
you stop the pacer?
uh,
Switch off. Let's see what happens.
So clearly now the IVUS has been done, angiography has been done. Make the hemodynamic little bigger now and try to see that patient was requiring some pacemaker. We have given atropine, but not aminophylline. If there's any question, you can end up with the aminophylline. But this is okay now. It looks all right.
What?
Atropine.
Atropine?
Yeah.
Maybe it doesn't work in this guy.
No, but this much calcium. This is
No.
embolization.
Atropine
Yeah.
is not showing that he's getting atropine.
Yeah. No, but that's okay because without that he was a little troublesome. So now this is case now will be managed just the medically and the question always comes that how do you follow these patients? The post PCI trial showed that routine stress test even is not helpful. Even diabetic heart failure, I mean on patient with hemodialysis, no patients we always used to believe and we just follow them clinically. So this is what we're going to do with this case with a 2-vessel disease. Excellent results. Emphasis will be more very tough to take out their what are you doing?
No, I wanted a RAO picture just to see the distal vessel. It is okay.
No, that's okay. I don't think we need to do.
No need, okay.
Yeah, don't need anything. All right. Any question? Otherwise, we'll start our the case discussions and rest of the presentation. You want to show your some calcific nodule studies?
Good?
Yeah. Okay. You want to go?
No, I don't know what they have. What did you put?
Excellent case, sir.
Yeah.
They have no interest.
We must compliment you. Excellent. A lot of learning points in this case.
Beautiful, yes. And
What did
same,
you find?
again, we do about
did you sit for 1 hour?
75 atherectomies per month, 60 are rota, about 5-6 are laser, and about 5-6 are orbital. Orbital number has gone down actually, sometimes even 1 or 2. The laser basically for uncrossable lesion and unexpanded stent. So many cases with unexpanded stent, laser is a great device, although we use rota also, but excimer laser is a very good device for that. Orbital does not work there, IVL can work, but laser is our first line treatment. And there you actually can use the dye. You don't need to do a saline flush. Creating bigger vapor bubbles. Now the laser catheter, the machine has gone through major changes. We just acquired the new ones, and so I'm sure those will come to India also. And there's a very rapid setup. In the past, used to take about 5 or 8 minutes. Now it takes less than 1 minute to ready. Catheter is the same, but the equipment, machine has changed significantly. So now only question is that there is so much gimmick going on in India, and we keep hearing so much that laser evaporate the plaque. You don't need the PCI, and every week I get 1 or 2, believe me, patients or somebody else sending me yesterday again sent somebody laser evaporate the plaque. You don't need anything. I said please. It has a good device, but has to have an appropriate indication. And appropriate indication, I would say calcific thrombus 1, unexpanded stent 2, and third is you cannot get any device in. Even your 1O balloon does not go, and you have done a wire, and then there I think the laser will make it through. So Anu, what you have now?
No, we can just show the IVUS aid.
You want to say US IVUS aid?
Yeah, I mean, today we wanted to show you a little bit more on the IVUS. So if you see there, we have one of this app for the IVUS, where more important, I think, imaging, a lot of people want to do imaging, but the question is, image interpretation. So we have a lot of images with annotated, so that will tell you exactly what you're looking for, or if you see something like that, what is the interpretation, and learning, which is about quizzes that are there. So,
Yeah, he's moving it. He's moving.
who's moving?
Yeah.
Yeah, so image interpretation, let it play there. So if you see exactly, I think that's what Kiski was also focused. We also have a OCT aid, octade it is called. Yeah, exact if you see here. So what is the calcium and how does that look? And this is an example of a nodule and at the pullback. And the other one is neointimal hyperplasia. And now we are actually teaching a lot of this during our CCC imaging, which is every other month, first Friday. And cases, all these cases are from here, our live cases where we have done imaging. So you can go through this each cases and learn by using. So it is not just understanding the image, and then if you see something, what would you do in that particular case? So all that are included. So what happens also, the recently we released hemodynamic aid, more of the discussion on FFR, IFR, RFR, microvascular disease, how to how to do them and how to interpret, because that's the key. Learning how to do is okay, but interpretation and management is what is being taught also in this new app. So these are the whole lot of apps. We have hit 15 now.
Beautiful.
For this.
Any questions for our esteemed moderators, the panelists, or any want to put any audience in the chat box?
Just one chat there.
Yeah.
No, maybe.
So, Dr. Kinney, how does one get to use this app?
If you have cardiology, if you see, go to cardiologyapps.com.
Right.
And there you have the way to download either on the iOS if you have Apple or Android.
Okay.
So if you go, you see that? Can they now download it? If they, not yet. No, not that. Yes. IVUS said they can. No, can they use that
Barcode, QR code.
Can they use a QR barcode and download it right now?
That's for cardiologyapps.com.
Yeah, cardiology apps.
Yeah.
Okay. So if you go to cardiology apps and then you click on the IVUS, you see.
Okay.
No post dilatation for certain segments. Yeah, they have put a chat, no post dilatation for certain segment. You've seen the final IVUS. Well opposed. So go back, right?
Yeah.
Somebody put a thing in the
that's
chat.
fine. That's
Yeah,
okay. So means question comes that we did not post dilate, which is a routine practice. But if you had done a lot of pre-dilatation and pre-plaque modification, we have used the rotablation, we have used the cutting balloon. So we have done all the pre. The post, you're for 12, 16 atmosphere, stent is fully expanded, good lumen, you're more than 7.5, your work done. If area is not expanded, that area you'll go and post dilate, but we didn't find any of them. Yeah.
Dr. Sharma, if I may ask,
no, hold on.
Go
back. How do we get? There are questions coming up.
Yes.
Hemodynamically, little unstable patient, would you choose a rotablation or orbital? What is your preference at your center, sir?
Beautiful point. So question comes down to, remember until now we learned that slow flow happens less with orbital versus rotational atherectomy, right? I mean, because the particle size and the fast our flush. But turns out to be only one trial which showed higher slow flow compared to the competitor, none of the rota trial, only in Eclipse. The slow flow occurred in 1.8% compared to less than 1% in the non-orbital atherectomy group. So question in the past was, then hemodynamically unstable patient, would you use rota or IVL? I would say, sorry, rota or orbital. To me, first preference will be if you can get IVL there. If you think that IVL cannot go because very tortuosity, and so my clear-cut preference will be a small rota bar. And that has been, and now after eclipse, I can clearly say that rota will not increase more slow flow. And our publication was the same. We published of 1200 patients, comparing about 950 rota with 250 orbital. We saw no difference. No difference in the slow flow. We found more dissection and more perforation in the orbital compared to rota. Same thing what they knew in the eclipse trial. Although eclipse showed higher orbital atherectomy slow flow, but our comparison was RA versus OA, and we found more dissection with OA and slightly higher perforation.
Make that picture
So one of the reason was that some cases they knew in the eclipse, they went 120,000 RPM. To me, they should eliminate, and I'm working with them now, it has been with the Abbott, eliminate 120,000 RPM speed. They should be 40 or 60 and 80. You don't need beyond that. Very effective device. Cause deep cuts. And therefore, so go down speed. You know, we have the micro crown. Their speed was 40 and 80. 40,000, 80,000.
Oh.
There was nothing. Yeah, micro crown. Yeah, it was 40,000 and 80,000. But that was, problem was, they put a ablative surface at the tip, gap, and then the crown. So what was happening is that it was going into the lesion and torsing in between that gap. It was not continuous diamond chip. So that the device has been discontinued. So key is the device of the low speed, in my opinion, orbital will win one day, but has to go to the low speed. I'm working with them, and let's see, I have to visit their plant and come up with some good recommendation, just like I've done with the Rotopro.
Great. So one extension of the same question. If you're going to keep IVL, you know, it's somewhere ostial LAD or a distal left main, don't you think it occludes for a longer duration to deliver therapy and then, more hemodynamic effect?
I can tell you 100%. The 3 years ago, I'm moderating a case in CRT. It was a 80% distal left main and 85% ostial LAD, ejection fraction 30%. And they wanted to do this case without balloon pump, without impella. I told them, I was one of the moderators, I said, guys, this case should be done, if whatever technique you use, you should use some support device, maybe a balloon pump. It's not that you need impella. But then they say, okay, we are going with IVL. I said, what? We are going with IVL in this case with the RCA closed and ejection fraction 30%. I said this patient will be in hemodynamic trouble.
Rota versus
You may do a rota, quick, get a lumen,
Yes.
then use IVL.
Yes.
And guess what happened? Their first IVL, within third pulse, blood pressure became 30. Urgently, they had to put a balloon pump on that case.
A lot
I
of
predicted
questions.
that. Yeah.
So
Then-
the one question was the use of laser in ISR.
ISR,
Yeah. Did you answer that?
No, we said that unexpanded stent, we said earlier, our laser is good. In ISR also is good. There are some trials in the past have shown that laser does work in the ISR, more so in the unexpanded stents.
Yeah, but unexpanded stent is not always. Our experience wise, yes, what is laser was approved mostly for ISR, and also what happens is ISR, especially if you think it's chronic total occlusion, where you know your CTO wire has crossed the lesion and now you cannot get any other wire down, then laser is very helpful. You can do one run of laser and then decide you want to upgrade it to a second ablative device, which is
So
rotational
somebody,
atherectomy.
let me put to all the audience, there are 3 approved and good indications for the laser. 1, ISR, particularly unexpanded stent. 2nd, calcific lesion thrombus. 3rd, the uncrossable lesion, because you have put a wire and nothing else is going. Everything else, some can be used, but these are the 3 main indications of the excimer laser in at this time when other devices are available.
Acute MI with large thrombus burden in
With
young
calcium,
person.
yeah.
Without calcium, would you use, sir? No.
But I mean, it doesn't help because in that case, I think your aspiration, although tapas and taste trials show different, but our thrombus burden, what we see in Indian population, you do them without aspiration, that a whole artery will shut down. So those cases will do aspiration and then you put a stent. Only question will be like vein graft, you have thrombotic lesion, but the thrombus there, and there is a calcium, laser will be very good in that situation.
So the other question is, what is the rota solution, or what do we use? So yeah, it is half normal saline, where they have you put a nitroglycerin, then the verapamil, as well as we use heparin and some rotaglide solution. Depending on, they always ask the patient if they are allergic to eggs or olive.
Yeah.
I don't know the olive, but there is a emulsion apparently that they use. But they ask the patient if they no, otherwise they use. Go to the not orbital.
But that's not available. So just to say, Rotaglide is not available in India. So just to tell, we use a very simple principle. 500 half normal saline, 5 milligram heparin, 5 milligram nitroglycerin, 5 milligram verapamil. I know a lot of people we use Cardine, which is completely fine in India. Verapamil does cause some bradycardia, so some people want to change it to Cardine, that's okay too. So some vasodilator, calcium vasodilator is needed. So 5-5-5 principle, will never forget. Yeah.
No, you were talking about the speed, and I'll tell you low speed why it may not work. Now let's go back to the physics principle, right? One is differential cutting and orthogonal displacement. Okay, orthogonal displacement means you are safe. There is calcium, the inelastic will go 90 degrees deflection. So differential cutting means when there is calcium which is hard, only that part is cut, inelastic will be deflected. Okay, the typical example they give is a razor blade. Only hair is cut, your skin is not cut. That's how rotational atherectomy works. So let's go the rotor drive. So you need a certain speed for it to function, for it to rotate. Okay, so lower speed may not be the answer. Then coming back to your question again, why they went to 80 and 120? See how orbital atherectomy works. It orbits, go round and round. And the physics principle there is equal to Fc mv square divided by r. R is a radius, which is a rotation. So if you want a speed and the velocity, okay, it is inversely proportional. So if your radius becomes smaller, low speed may be okay. With a higher speed you need to reach, for it to reach the vessel wall, you need a higher speed. So if you go like a 40,000 RPM, orbital may not be the way to go. You need a certain speed for that mass and velocity to rotate and work.
All right. Any other questions? And this
those are the two wires you were talking about. Right? No, that is Viper. But rotational atherectomy wires, which we spoke on. Go back. Okay, yeah. So this is what I think floppy. You see that 2.2, and extra support is slightly longer, 2.8.
Yeah.
But length is the same, except the core to tip is a little different. But you have also wanted to know which are the cases, right? Which are the cases we are going to use extra support wire, which is very clear there. Definitely for distal lesions, most important we use is ostial, and definitely ISR, because we get a good wire bias in that particular cases.
All right,
all this is available in the apps that we have created.
Yeah.
Everything
Guide app.
Yeah, everything that I'm showing you is from the apps.
Guide wire app. All right, if no more questions, so we really thank everyone, all our moderator and panelists for this exciting event, and then we'll be ready for the for our didactic discussion. So, Dr. Subhash, you start the presentation. I'll join you in about 5 minutes once I go to my room.
In the chat.
Huh?
Any other question in the chat?
Yeah, any other questions on the chat? No. Done.
I think we've
All right.
answered most of them.
I'll see you shortly. Okay.